mouse or otherwise ensure your screen is not idle. I will be monitoring the Q&A, and we will do our best to address as many questions as possible, time permitting. We'll be sharing a recording of this program with everyone who is registered so that you can share it widely with your networks. Now, before I introduce our esteemed panelists, I would like to take a moment to thank the members of the Planning Committee and the ABA staff members who provided much needed support so that we can all be here today. Victor Marquez, Araceli Munoz, Kristen Rossi, Wendy Shiba, Katie Larkin-Wong, Ashley Hill, and Allie Kilsgard. Thank you all so much for your help. And for those who don't know me, I'm Amira Hazenbush. I'm a family formation lawyer based out of Los Angeles, California. My private practice focuses on helping build and protect families via adoption and assisted reproduction with a special focus on LGBTQ+ families. I'm also the family law section liaison to the Commission on Sexual Orientation and Gender Identity. Just one more note before we begin today. There may be a few acronyms thrown about while we chat, but the one most likely to come up most often is ART. ART, A-R-T, stands for Assisted Reproductive Technology. So if you don't know, now you know. Without further ado, I'm honored to introduce you to our wonderful speakers. So first, apologies, Desireé Luckey was unable to be here today, but we have a great panel for you either way. So we'll start today with Robyn Powell. Robyn Powell is a visiting assistant professor at Stetson University College of Law and a senior research associate at the Lurie Institute for Disability Policy at Brandeis University. As a proud disabled woman, Dr. Powell's scholarship and advocacy focuses on the intersection of disability law, reproductive justice, and public health law. Previously, Dr. Powell served as an attorney advisor at the National Council on Disability, NCD, an independent federal agency that advises the President and Congress on matters concerning people with disabilities. She's also served as the Disability Rights Program Manager at the Equal Rights Center, Assistant Director for Policy and Advocacy at the Disability Policy Consortium, and staff attorney at Greater Boston Legal Services. Dr. Powell is one of the country's foremost authorities on the rights of parents with disabilities and is the principal author of NCD's report, Rocking the Cradle, Ensuring the Rights of Parents with Disabilities and Their Children. Next, we have Cathy Sakimura. Cathy Sakimura is the Deputy Director and Family Law Director at the National Center for Lesbian Rights. Cathy also founded and oversees NCLR's Family Protection Project, which improves access to family law services for low-income LGBT parents and their children, with a focus on families of color. She received her JD from UC Hastings College of the Law and her BA from Stanford University. In 2021, Cathy received the Dan Bradley Award, the National LGBTQ+ Bar Association's highest honor. She is co-author of the book Lesbian, Gay, Bisexual, and Transgender Family Law, and later this month, Cathy will start a new position as the next Executive Director of Legal Services for Children. Finally, we have Virginia Hart. Virginia Hart has been an insurance broker for over 25 years, the last 20 specializing in insurance for all aspects of assisted reproduction. As founder and CEO of Art Risk Financial and Insurance Solutions Incorporated, she remains current on insurance issues and works with her clients to find the best solution, whether it be through commercial insurance, specialty products, or financial case management. Virginia is known as an industry leader in the assisted reproductive technology field. She is a requested guest lecturer at the ABA Family Law Section conferences, the LGBT Center in New York City, as well as the Society for Ethics in Egg Donation and Surrogacy. Additionally, Ms. Hart has published an article in the ABA's Family Advocate magazine and serves on the Men Having Babies Advisory Board. As CEO, Virginia works to develop products and cost management solutions to respond to the ever-changing insurance world. Helping to find financial solutions for people building their families is one of Virginia's greatest joys, building families and making dreams come true. And with that, I will turn things over to Dr. Powell.
Thank you, Amira. And let me just share my screen. All right, 1 second. Okay, I'm assuming everyone can see this. So thank you again for inviting me here today. I'm going to spend some time speaking about people with disabilities. And before I do that, I just want to emphasize why this matters. So we know that 26% of the US population has a disability, which makes us the largest historically marginalized community, and we are often excluded from these conversations. And I think that hopefully by the end of today, you will see that that is not a good thing. Disability really does affect everyone, and it's something that we need to be thinking about when we're talking about assisted reproductive technologies, reproductive health, and more broadly, reproductive justice. And when I talk about disability, I want us to really think broadly. So you can't maybe tell, but I'm a woman in a wheelchair, and I'm what you think of when you think of disability. And that's probably because the stupid parking spots have the wheelchair symbol. So we just assume that you can only have a disability if you are in a wheelchair, when in fact, most people with disabilities do not use a wheelchair. So I want us to really think broadly. We should be thinking about physical disabilities, sensory, so people are deaf or blind, people who have intellectual disabilities or learning disabilities, and people who have mental health or psychiatric disabilities. So really today, when I'm talking about disability, I'm talking about it very broadly, and later I will talk about the legal definition of disability, which is also very broad. So that is really who people with disabilities are. And again, hopefully you will see by the end of this why disability should be included in these conversations. And why they need to be done, and why it needs to be done so in a very intentional way, which is why I was very excited about this presentation. So with that, I want to really set the stage. And when I'm talking today, I'm going to be talking from a reproductive justice lens. And reproductive justice, for those who don't know, was developed by women of color in the early 1990s through Sister Song, which is the Women of Color Reproductive Justice Collaborative. And when I think about these issues around reproduction, I think of them very much from a repro justice lens. So repro justice is the right to have a child, the right to not have a child, and the right to parent a child or children in safe and healthy environments. So I'm going to, of course, be talking about assistive reproductive technologies, but I'm also going to be talking about other related things related to reproductive justice and people with disabilities. So really, I think I would encourage everyone to really think about these issues from this repro justice lens. And I think that all of this is particularly relevant and important and timely because unless you've been living under a rock, you know that all of this is about to explode at the Supreme Court. So I think it's really important that we bring in not even historically marginalized, I would say historically excluded communities from these conversations. And I think that when we're thinking about sort of our path forward, we need to make sure that we're including all the communities, especially those who are going to be most acutely affected. So when we're talking about reproductive rights for people with disabilities, you have to start at the beginning. And historically, we have always implemented and enacted laws and policies that have restricted people with disabilities from reproducing. And this dates back to the eugenics era. And on this slide, you can see there's a photo of the eugenics tree, which sort of uses all these terms around eugenics. And then on the right side is a picture of Carrie Buck and her mother, Emma Buck. And to give you a little understanding, let's talk for a minute about Buck v. Bell. So Buck v. Bell was the Supreme Court decision from 1927, which really gave the blessing to Virginia, the state of Virginia, to sterilize people who they deemed socially unfit or who should not be reproducing. And unfortunately, this included Carrie Buck. So Carrie Buck was 17 years old when she became pregnant after being sexually assaulted by her foster family's relative. And really, I think to sort of hide this violence and the pregnancy that occurred, she was sent to an institution in Virginia. And her mother was already at this Virginia institution, and they were both there because they were considered what they said was feeble-minded. And feeble-minded was this really loose and offensive term that described people with disabilities, but it also described people who were poor, who were really just people that we did not think as a society should be reproducing and who we did not really want in our society. So her mother was there because she was a single mom who was living in really deep poverty, and Carrie Buck was there, of course, for the same reason. So Carrie went on to have her baby, her daughter Vivian, and shortly after giving birth, Vivian was immediately removed from Carrie and sent to live with those lovely foster parents. And Carrie never saw her daughter Vivian again. After that, Carrie really wanted to get out of the institution, and in order to do so, she was told that she would need to undergo a sterilization, which was consistent with Virginia's new law that required that anyone who was leaving institutions would be required to be sterilized. And Carrie's appealed this, and it went all the way up to the Supreme Court. In a really egregious decision, Justice Oliver Wendell Holmes Jr. said, in part, 3 generations of imbeciles are enough. And what he meant by that was that he assumed that Carrie Buck was a quote unquote imbecile. He assumed that her mother was also that, and they assumed that her daughter was also that. Now, I say assumed because years later, research really showed that none of those people had disabilities. In fact, her daughter did really well in school until she died at age 8 from a very unrelated disorder. And Carrie lived very long life, and her biggest regret was always not being able to have children. And so this case really showed how we used this pretense of sort of disability to sort of subjugate reproduction and really subjugate disabled people. And we used it to not just talk about people who actually had disabilities, but other socially marginalized communities. And eugenics resulted in far over 75,000 people being sterilized. The number that's usually thrown around is 70 to 70,000, but I can guarantee you that no one was collecting numbers on who they were sterilizing in the early 1900s. So I don't believe that number. And we know that these practices endure today. And in fact, the National Women's Law Center came out a few months ago with a report that found over 30 states still have sterilization laws on the books that allow for sterilization of people with disabilities. So the past is very much the present. And that's what I want you to think about. So when we had eugenics, there were 3 threads that sort of underlined it. And the first was that people with disabilities needed to be protected. They didn't know better. They didn't know how to protect themselves, and we would protect them by sterilizing them, which is absurd. The second was that their potential offspring needed to be protected because no one would want to be parented by a person with a disability. And then the third was that society needed to be protected because having a disabled parent would be a burden on society. And those beliefs still continue today. So with that, I want to move on, but I did want to I think understanding how we got to where we are today and why the past is really very much the present, we have to understand the effects of eugenics. And while eugenics may not exist by name, it still very much exists by practice. So when we're talking about reproductive health care providers and other ART providers or assisted reproductive technologies, we have to remember the legal framework, the laws in which these providers must exist. And there are 3 main laws that apply with regard to disability and these providers. And that is the Americans with Disabilities Act, specifically Titles 2 and Titles 3, Section 504 of the Rehabilitation Act, and then Section 1557 of the Affordable Care Act. And so Title 2 applies to any state or local government agency, so that could be hospitals and so forth. Title 3 rather of the ADA applies to any private hospital or healthcare provider, so doctors' offices and those types of things. Section 504 of the Rehab Act applies whenever an entity receives any federal money, and this can be even Medicaid or Medicare. So anytime a provider receives federal funding, they now have to comply with Section 504. And then finally, Section 1557 really adopts the principles of Titles 2 and Section 504 that really just says that healthcare providers cannot discriminate on a wide range of identities, including people with disabilities. So the legal definition that all of these laws use is that a disability is defined as a person who has a physical or mental impairment that substantially limits one or more major life activities of such individual, a record of such an impairment, or being regarded as having such an impairment. And we should remember that major life activities can include reproduction. There are cases that say that. So this is a very broad definition, which is why I'm saying we need to think about disability broadly. And because of these laws, there are several things that providers may not do. The first is that they can't establish this criteria that screens out people with disabilities from benefiting from their services. They also cannot fail to make reasonable modifications that would enable someone to access their service. They can't take steps to really make sure, they can't really deny people with disabilities services based on their disability. They can't treat them differently. They have to provide auxiliary aids and services, which are really just things that help communication. So sign language interpreters and those types of things. They have to remove architectural barriers. So they have to make sure buildings are accessible, and they can't they have to make sure that they do not fail to make a good or service available through alternative methods if such methods are readily available or achievable. So if something isn't accessible, they have to try to come up with a new way, unless that is not possible. So you can see that providers have actually quite a bit of legal mandates when it comes to people with disabilities. But what you'll see in a minute is that these mandates, although the Rehab Act was signed in 1973, so they've existed for almost 50 years, some of these mandates, they have not helped in this department very much. So I want to start, of course, by talking about issues around assisted reproductive technology for disabled people. And I want to start by talking about this case from the early 2000s. So this case involved Kwana Chambers. She was a Black blind lesbian, and she had been going to the Rocky Mountain Women's Healthcare Center for fertility treatments. And they stopped this in 1999 after she had undergone 4 rounds of insemination. At that point, they refused to treat her any longer, saying that she posed a direct threat to the safety of her yet to be conceived baby. And in doing this, they demanded that she undergo an occupational therapy assessment of her home to make sure it was safe for a baby. They also talked at some point about how the clinic staff were concerned that she may have had trouble getting dressed while she was there. She had trouble getting to a bus stop. And at one point, they even talked about how they believed she had soiled her underwear and wondered whether she could keep a baby clean. These are things that came out in the court case. And really, according to an attorney for the clinic, the doctors were worried that she could not take care of a baby and turned her down because, and I quote, "it was the right thing to do." They said this case is about the moral and ethical responsibility of a physician. So she brought this lawsuit against the clinic, and after going through 2 federal appeals where she alleged that the clinic had violated the ADA, she ultimately did not win. So ultimately, she was able to do what many disabled people have to do, which is really provider shop. So she finally did find a provider that would treat her, and she now has at least 2 children that I'm aware of. But she had to go through all of this, including 4 rounds, before they decided arbitrarily that she could not care for her yet to be conceived child. And I think that this case really shows what disabled people encounter all the time. They're really encountering healthcare providers that presume that they are incapable of reproducing, or that they shouldn't be reproducing. And so with regard to assisted reproductive technologies, we see, as in her case, that discrimination and bias is incredibly common. And there are several surveys that have found that ART providers really do have a lot of bias and attitudinal, biases against people with disabilities and other communities. And they're allowed to have a lot of subjectivity, and this subjectivity really does lead to a lot of people with disabilities being discriminated against. We also see that there are financial barriers, and we will be talking later about insurance, but this is a real problem for people with disabilities who happen to live in high rates of poverty. Disabled people are amongst the poorest in our country, and they also tend to rely on Medicaid or Medicare, which typically does not provide a lot of help in the reproductive health world. So they have all of these financial barriers. And then, of course, they have these access barriers, whether a clinic is not physically accessible, whether they're failing to provide programmatic access or communication access, or even just transportation. Disabled people don't have access to the clinics, so they can't even get to the door of the clinic. And all of these barriers really do inhibit disabled people's access to assisted reproductive technologies. This is really critical because we know that ART is a really important healthcare service for a lot of people, and for disabled people, it can actually be a reasonable accommodation. So a lot of people with HIV, and this is an increasing thing, will go to ART because they have been able to use certain technologies so that people who have HIV can reproduce safely. And so this is really important, and it is a reasonable accommodation. I'm talking about this because people with HIV are considered disabled under the ADA. It also can be used as a reasonable accommodation for surrogacy. A lot of disabled people go the route of surrogacy because it is safer for them. They still want to be able to have children, and they decide that surrogacy is the safest route. So again, ART is really important for a lot of people with disabilities. And there are a lot of solutions that can be had. One would be the most obvious to me, which is, hey, providers should comply with the law. So they should comply with the ADA, the ACA, and Section 504. I also think we need to see increased enforcement. We just don't see a lot of people talking about disabled people reproducing. So of course, we're not going to talk about them using assisted reproductive technologies. And I think we need to really have this as a priority. We also need to ensure that providers are trained and have awareness about how to work with people with disabilities. I think Kawana Chambers' case really shows just the ways in which providers just have no understanding about how to work with disabled people. And then the final thing is we have to think about sort of issues around social determinants of health. If disabled people continue to live in poverty and not have access to insurance, they don't have transportation, they don't have adequate health care in general, assisted reproductive technologies is never going to be accessible for disabled people. And so we really do need to take this comprehensive approach to ensuring that art is fully accessible for disabled people. Again, I want to emphasize it can be a really important type of healthcare service for people with disabilities, and we need to ensure that it is fully accessible. So I want to talk for a few more minutes about other examples of ways that people with disabilities experience contemporary reproductive oppression. And in the first photo, we can see Free Britney signs. And you're probably wondering why I'm talking about Britney Spears. And a year ago, I would have said the same thing. But Britney Spears has actually, in many ways, been sort of exactly what I needed for my work. And her experience showed exactly what disabled people experience all the time. So I'm sure that everyone knows that Britney Spears was under a conservator for 13 years. And during that time, she was prohibited from doing a lot of things in her life, one of which was removing her IUD so that she could have another child. And what happened to Britney Spears happens all the time. I can't tell you the number of cases I've heard where disabled people are being denied just their basic reproductive freedom because of these conservatorships or guardianships. And so luckily for Britney, she has an enormous platform and a lot of money and resources, and she was able, after 13 years, to successfully get rid of her conservator. But if it took Britney Spears 13 years and all of those resources and the platform, you can imagine that most disabled people are going to continue to be denied reproductive freedom. And yes, Britney Spears would qualify as having a disability. I have no idea if Britney identifies as having a disability, but what I do know is that in 2013, she said in a documentary that she has bipolar disorder, and bipolar disorder is a disability. So whether she identifies or not, she's being treated as having a disability. So there are a number of sexual and reproductive health disparities disabled people experience. We talk often about the maternal health crisis in this country. And what we don't talk about is disabled people are amongst the highest individuals to have maternal morbidity and mortality. Disabled people are often experiencing really dire reproductive health disparities. And this isn't because of their disability per se, it's because they receive inadequate access to healthcare. And often providers just don't assume they are engaged in sexual activity or that they would want to reproduce. And so they just don't get the right healthcare. And I'm going to tell you, as a disabled woman myself, I can assure you that by the age of 30, I had been offered a hysterectomy more times than I could count. And none of it was because I had a medical reason to have a hysterectomy. And now I'm, of course, way past 30. But I think that if it's happening to me, someone who's well-educated and who has a lot of privilege, it's happening all the time. And providers are just not treating disabled people. Disabled people are assumed to be sexually unwilling or unable. They don't get just access to basic health care. And of course, that ends up in these maternal morbidity and mortality. There's also just a scarcity of comprehensive and accessible sex ed. Disabled people are often denied sex ed. That is a really important thing, and that's something that needs to be addressed because disabled people also have the highest rates of unintended pregnancies. Not surprising. Disabled people like Britney Spears are often denied reproductive decision-making. They don't get to decide whether they, get to take contraception. They are often forced, as in the case of Britney Spears, or other types of just reproductive decision-making. They also, on the other hand, have experienced a number of barriers to contraception and abortion. So there's this sort of paradox where some disabled people are being forced to terminate pregnancies and take contraception, and then another group of people with disabilities who aren't given any of those opportunities. And the problem with all of that is that no one's getting the choice. And a lot of people are making decisions for disabled people. And then there's restrictions on sexuality. If you're a person with an intellectual disability and you're living in a group home, you're often denied just basic opportunities to have relationships and sexual relationships. So there are all these issues. And then finally, what we don't talk about enough is threats to parenthood. Once a person does successfully have a child, they live under constant microscope of the child welfare system, which many call the family policing system, where they often have their child removed and have their parental rights terminated simply because they have a disability. So what can we do about all of this? I've given you a lot of bad news. So the first thing is, and we have to remember that disabled people are not a monolith. I have a friend who often talks about how disabled people are assumed to be pale, male, and stale. And in fact, most disabled people are not white men. So we have to recognize that people who are multiply marginalized, disabled people of color, and LGBTQ plus people with disabilities experience all of the things I just said at an amplified rate. All of those problems I just listed are worse for multiply marginalized disabled people. So we need to really focus on ensuring that multiply marginalized disabled people are having all of their rights. And if we can really disrupt these intersecting oppressions, we will help all disabled people and really all people, because when something's accessible for some, it's accessible for everyone. We also really need to center people with disabilities as leaders. We're not going to be able to come up with all the solutions unless we actually bring disabled people to the table and ask how we can address these issues. We have to protect autonomy and self-determination. People with disabilities need to be able to make decisions for themselves. We also need to ensure that they have access to sexual and reproductive health services and information, and that it's accessible and affordable for people with disabilities. And finally, we need to guarantee rights, justice, and wellness for people with disabilities and their families. And this is a long list of things, but it is really important. And I want to emphasize what I said at the beginning. As we await the Dobbs decision and we're trying to sort of come up with how our new approach is to looking at reproductive rights, I encourage us to really shift to a reproductive justice lens and think about all of the issues, because you only really do have choice when you have full reproductive freedom. So here's a few articles that I have written about these topics that I just wanted to mention, because I think that they get into some of these topics much more comprehensively than I'm able to do in the next 2 minutes. And then the last thing is I wanted to share a few other resources. So as Amira mentioned, I was the principal author of Rocking the Cradle. It's a report that's available online, and there's a complete chapter on assisted reproductive technologies and people with disabilities. And although the report's from 2012, which means it's almost 10 years old, nothing really has changed, unfortunately. There's also the National Research Center for Parents with Disabilities, where I am a co-investigator. They have a lot of information on these topics. And then I'm also a co-investigator at the National Center for Disability and Pregnancy Research. And with that, I want to thank you, and I look forward to hearing from my other panelists.
Wonderful. Thank you so much, Dr. Powell. That was amazing. And it makes me think a lot about the law that just passed in California that's now providing reparations to women who are incarcerated, who were sterilized against their wishes or without their knowledge often. So, hopefully we're seeing some movement forward in this direction.
Yeah, and I would just point out that over 50% of people who are incarcerated have a disability. So again, back to why you have to bring disability into these conversations. So
absolutely. So Cathy is going to pick up on this and take us through a bunch more.
Great. Thank you so much. And thank you so much, Dr. Powell, for that incredible presentation. And I think really sets the stage for a lot of what I want to cover, which is, other identities where people experience discrimination and oppression that impact how they access ART, how they become parents, how they are parents, whether they're recognized, and how they're treated legally and also by providers. And so I won't focus much on all of the aspects of how disability intersects on this, because it was such an incredible presentation already. But of course, as Dr. Powell mentioned, there are many people who have multiple intersecting identities. And for those people, all of these things are multiplied, and they experience discrimination in multiple ways and also in new ways in terms of how those things fit together. I think it's really important to look at how historically people have experienced reproductive healthcare, reproductive access, and the lack of reproductive justice as a setting the stage for what happens today. So as Dr. Powell was talking about, Buck versus Bell and the history of forced sterilization and the prevention of reproduction of people with disabilities, that of course also happened with other communities. As Amira mentioned, the forced sterilization of women in prisons, which is actually quite recent in our history, and of course, the forced sterilization of Native women for generations, and all leads to, and I think builds on this idea that some people are people who have too many children, that society needs to stop from having children. And some people should be supported in having children and given the opportunities to, have fertility care. And that pervades unconscious and conscious bias in how people access care, and how people are treated in terms of wanting to become pregnant. People assume that a low-income Black woman does not need fertility care to become pregnant and have children, even unconsciously, because that's such a trope that has existed in the societal discussion of, poor Black women are having too many children, and then the person who would need fertility care is typically an older white woman who is middle class. And that's really, I think, the narrative that drives a lot of the discrimination that happens. So of course, discrimination can happen in access, as in one of the cases that Dr. Powell talked about, where, the fertility clinics just won't provide care. That happens, of course, to people with disabilities, people of color, LGBTQ people, certainly in, settings where there's, a religious agency that has an anti-LGBTQ view. People can have difficulty accessing care there, but also in many other places. Even if you can access care, lots of the forms are discriminatory, especially for LGBTQ people, of, listing mother or father, or forcing you to say you're an egg donor when you are actually an intended parent, or a surrogate when you're an intended parent. And a lot of that is changing, but still exists. And people still end up signing forms that don't reflect the reality, and then later have impacts on the legal recognition of their families, which I'll cover a bit later. In terms of also just the challenges in accessing, of course, is the cost, which I know Virginia is going to talk a lot about insurance coverage, but also I think in the regulation of ART access, and the coverage for ART benefits really has in many ways focused on the most expensive aspects of ART, and has left out consideration of how there is assisted reproduction that isn't very expensive. And that is what, in many ways, probably the majority of people using assisted reproduction are doing, is at-home insemination with known donors. And the way that things are structured, your choice really is to pay a lot of money and have a very invasive experience medically, or to be completely informal with basically no medical intervention, which, is essentially free or very cheap, but it takes out, screening for STIs, the protections that people have for who is a parent and your donor not being a parent, and just some of the basic medical care that people would otherwise get in conceiving through assisted reproduction. And by kind of creating two systems where we have people doing this very informal, completely outside of the system care, which can be really wonderful for people, but it also isn't easy to get into the system of care, even in small ways, that can protect their health and their families and legal recognition of how their families are structured. And in many ways, that's driven by the fact that the industry and the people who do have power and money are those who are accessing care at these higher intervention levels, people using IVF. There's obviously, if you need IVF and you're using it, it is expensive. There's possibilities for insurance coverage, and often that is, the focus of the discussion. So all of these different ways that people kind of have barriers to accessing ART and becoming pregnant when they want to be also can apply to surrogacy. So of course, surrogacy has incredible costs and typically involves some kind of ART procedure. Sorry, I'm by an airport here. Long one. But often when you see low-income people needing to use surrogacy because they intended parents don't have a uterus or they can't become pregnant, it's often done as informal surrogacy, which people don't really talk about very much, but is very much like at-home insemination, where someone you know agrees to have a baby for you and is inseminated at home. And there's absolutely no legal protections for this. There's no special insurance coverage, and there's no protections for parentage because no surrogacy laws support surrogacy of this nature. I mean, for good reasons, because you do need to ensure that the person giving birth really truly wanted to be a surrogate. But because of the cost and the barriers, it is a way that a lot of people have children essentially outside of the system. And if anything goes wrong, a lot of challenges arise. Another issue that specifically impacts people of color in using ART is the lack of gamete donors of color. And this is particularly true for Black and Native people, which is because of a lot of the history of discrimination as well. The sort of loss of Black fathers to the criminal justice system or the criminal injustice system also creates this idea that you don't want to be fathering children that you don't know. I think also creates a barrier to becoming a sperm donor. Banks are not seeking Black donors. It's not really seen as, a group of people for most gamete banks who are sought out. And similarly for Native people, it's very difficult to find a gamete donor unless you're using a known donor who is Native if you're in a Native family. I don't have a presentation. Thank you for asking. You just have to listen to me talk. I don't have any slides. I'm taking over Desiree's presentation last minute, so it just didn't work out. But I'm happy to send any links or share anything if folks want. Thanks for asking. Also, in terms of other groups, in terms of restricted access, obviously language access is an issue for all kinds of reproductive health care outside of the ART context, of course, in the ways that abortion and related care is restricted, makes it very, very difficult to obtain that care. And to the extent that you have barriers to figuring out complex systems, it does tend to exclude people, especially people who are non-English speaking, people who have less income, lack of access to transportation. And there's so many ways, of course, that lots of different barriers come into play in accessing reproductive health care. I want to specifically touch a little bit on transgender people and specifically accessing ART and reproductive health care and the challenges with fertility preservation is that there's very little coverage, of course, for fertility preservation for transgender people who are undergoing transition-related care that leads to sterilization. And even if there is potentially coverage, there's a lack of education and understanding of doctors who are potentially providing this transition-related care to the impact on the ability to have children. I think there's a lot of assumptions that transgender people don't want to have children as well, and don't want to have biological children, maybe don't want to become pregnant, and so it often isn't discussed or offered as an option. And particularly as younger people are being open about their identity and feeling that they can live in their authentic selves, that they potentially are needing to make a choice at a younger age about potential procedures that could lead to sterilization. And even aside from those procedures, long-term hormones can have an impact on fertility later, even if you were to stop them, and often people aren't counseled on that. And, just how can you have fertility preservation, especially for people with eggs, which is much more difficult and expensive, of course, to preserve. And then, certainly if you do become pregnant as a transgender man or non-binary person, there are a lot of challenges in terms of accessing pregnancy care and childbirth care and the discrimination that people experience there. And Dr. Powell's talked a little bit about the maternal mortality rate. Certainly, there are many communities that experience much higher rates of death and negative outcomes in childbirth. And I think there has been, thankfully, more attention to the issue that particularly Black women and other Black people who give birth, that their mortality rate is 3 times higher than the general population, even given all the same potential access to care. Before, I want to talk a little bit about what happens when people do actually manage to receive care and become pregnant or have children, and what happens in terms of the recognition of families. And this is an issue, of course, that is very important to LGBTQ families, but really is important to all parents who have children through ART who are not genetically related to their children. I think that, if you appear to be a cisgender, different sex couple with children, you're less likely to be questioned about your children's parentage. But certainly anyone who is not a genetic parent or who gave birth to or who didn't give birth and used assisted reproduction potentially is at risk for being recognized as a parent in many states. Most states do not have comprehensive laws that address the parentage of children conceived through ART. There are some states that have really great ones. Oh, sorry, go ahead, Mira.
No, I was going to ask you if you could address the question that comes up so often about whether being on a birth certificate is enough.
Thank you. I'm so glad you asked that question because it's such an important one. And I think, we feel like we move through the world and we use our children's birth certificate to prove that we're their parent at school and the doctor and traveling. And so it feels like a legal document that says we are parents. But unfortunately, it doesn't actually have a binding effect on whether we're a parent if our children's parentage was actually questioned in any kind of legal proceeding, which could arise for all kinds of reasons. Birth certificates are a great way for us to show who our kids are, to show that we are parents of our children in our everyday lives, but alone they do not create parentage in a legal sense. It is the underlying law of the state where your case is, where there's jurisdiction over the question of who your child's parents are, that determine whether you're a parent. And so even if you live in a state that has comprehensive laws, if you move or potentially even, have something happen in a state that does not, that your family is at risk. And so a lot of states don't have comprehensive laws that address all the different ways that people conceive children through ART. And so even if you're on the birth certificate, you may not be able to be recognized in that state as a parent to your child, which of course can lead to all kinds of outcomes that are terrible, losing custody of your child, your child not being able to have benefits from you, your child not being able to inherit from you if you pass away, has, a lot of impacts on your child and you and your relationship to each other. A lot of states have older versions of ART laws that came from the 70s when there first started to be laws addressing people using ART that were focused on different sex married couples with infertility who are using sperm donors through a doctor. And so many of the laws are limited to that sole situation and only recognize a husband of a woman who gives birth as a parent if they used a sperm donor while they were married. And that every other form of ART doesn't get recognized as the donor being a donor and the non-genetic parent being a parent. Many of those laws have been applied to same-sex couples where one gives birth, even though the laws on the books are still very gendered. There is a movement to remove both the doctor's requirement and the marital status requirement. And so many states have done that, but a lot of states have not. And there's even a small handful of states that have no laws on this at all. And even in that situation where you're a married couple who used assisted reproduction, you may not necessarily be recognized as parents. And this, can lead to, for low-income people, you losing your child and also your sperm donor, if they're known, becoming a parent, being liable for child support, to reimburse public benefits that you have sought. And so this can be done even if all the parents agree and the donor agree that they don't want the donor to be a parent. The government can, especially for low-income people, force you into that arrangement.
And we're seeing really recent cases on this, Cathy, right? Like out of Idaho and Oklahoma.
Yes, absolutely. And it's, I think it's something that's come up a lot throughout time. And especially because low-income people are more likely to use at-home insemination with a known donor, and they're the ones that get subject to these actions, that this comes up a lot for low-income people who have sought Medicaid for their child, who are on welfare, who've had to seek some kind of benefit, and then they are required to cooperate in identifying the genetic father of their child. And if there isn't a law that recognizes that that donor is not a parent, then the state has essentially interprets the federal obligations to require the state to identify the donor as a father and have him reimburse the state for the benefits the child received. This is so much here. I want to talk a little bit more about marriage in specific. And I know Amira mentioned a little bit the impact potentially of Dobbs and, what impact that might have on ART. And I think those things obviously go together because of looking ahead to the future of what potentially could happen with the reduction of constitutional rights through Supreme Court decisions. So, of course, I know there's been a lot of talk about if Roe is overturned, not just obviously the restrictions on abortion, but leading to significant restrictions on ART, including IVF and surrogacy, and even forms of birth control and other reproductive health care. Of course, this could have a very significant impact on the ability to use ART and surrogacy if there is not ability to do genetic testing on embryos all embryos have to essentially be implanted in an attempt to become create a pregnancy. If surrogates cannot do selective abortions or cannot choose to have an abortion, it obviously has a really significant impact, not only on parents trying to become parents through ART, but on the women and other people with ova and uteruses who participate in ART as egg donors and surrogates, and their ability to make their own healthcare decisions in that process. Certainly, if there is an impact on the ability of people to marry, of same-sex couples to marry, and LGBT people to be recognized as married, a lot of the parentage protections are based on marriage. And that is the way in many states that people get recognized. And that, of course, can have a significant impact on whether or not you're a family, on your ability to access care and your ability to be recognized as a family. For that reason, I think it is really great that a lot of states have moved forward with legislative efforts to change this, to have gender neutral language, to have expanded ART provisions, to recognize and create free paths to the protection of parentage that don't require people to do an adoption or to go to court. And understand what they need to do to protect their parentage. So one effort that I've been really involved in is the Uniform Parentage Act of 2017. I was on the drafting committee and I'm on the enactment committee for the UP of 2017. And it does so many wonderful things in all of these areas. It takes away any kind of marital status requirements, any kind of doctor requirements for families being recognized who use ART. It provides a free, easily accessible process for people who are not genetic parents to have something that is not just a birth certificate, but that is required to be given full faith and credit in every state. That is called voluntary acknowledgements of parentage. many different forms of that term are used across the country, but it's essentially a gender neutral way to access voluntary acknowledgements of paternity. And I'm sorry, I can't see this comment. Anyway.
So I'll throw in what the comment is, because I think it's a really interesting conversation point for us to talk about. The commenter says, please stop calling them low income people. They're paid the lowest wages in this country. This does not make them low income. So I think it is really important when we talk in all of our different communities about the language we use and how we're centering different issues. And so absolutely considering that, it is not the people who are low income, it is the wages that are paid to them by their bosses and the companies that they work for that is impacting those folks.
Yeah, and thank you so much. And the way that society has set things up to allow for that and to allow for wage theft by corporations and to concentrate wealth in ways that, has only increased over the last several decades. So thank you so much. So I think that there are a lot of ways in which states can be acting through legislative action to try to improve the situation for people using ART in all different forms and assisted reproduction that doesn't have the T, things that are at-home insemination. There are many ways that states can create better systems for people, and a lot of them have. And I think it is an exciting moment of a trend of states really looking at this, and quite a number of states are considering this. And we need more action to work on ensuring that parentage is recognized for families who are conceived and created in many, many different ways, as well as I think what Virginia will talk about is a need for better insurance coverage and medical care access for people to use ART, regardless of income and ability to pay, and better enforcement of laws about discrimination and in terms of accessing care and experiencing discrimination from providers. I know that was a lot of topics, and so I'm going to finish up there and let Virginia talk.
Cathy, thank you so much for covering so much. And I think we had a great comment from one of the participants. And so I wanted to share this because I think it's also the perfect transition. And Cathy, for you, there is a question about, could you provide the names of any of these case examples where courts have forced people with informal ART arrangements into different parentage arrangements, i.e. forcing the sperm donor to be a parent and not recognizing the parental rights of the parents that used informal ART to conceive their child. So maybe we can put that in the chat while we're talking, and that way they'll have direct access to that. And the comment before we move over to Virginia says the use of ART is also usually considered from a mindset of being a married heterosexual opposite sex partners, which we talked about, especially since infertility is only considered after a certain amount of time of frequent insemination, which means LGBT women are not given appropriate consideration for infertility treatment, which is exactly right and exactly what Virginia is going to talk about. So that was the perfect transition.
Okay, well, thank you for having me on the panel today. And I thought first I'd start and give you just a little brief overview of healthcare in the U.S. And I think we can all say that the system is not perfect by any way, shape, manner, or form, and is broken in many, many ways. The Affordable Care Act actually did a lot to try and fix it. And I often joke with my clients and say affordable for whom? Because unless you can qualify for a subsidy, et cetera, I don't think $1,000 a month for a family or somebody who's 65 or 64, because 65 you get on Medicare, they just live for that birthday, is necessarily affordable. But currently there's 9.2% of US citizens are uninsured, 5% of whom are children. Working adults make up 13.9% of the uninsured. Uninsured women are actually are 12%, which is actually down 20% prior to the ACA. So the ACA has allowed more affordable access to care and has lowered the number of uninsured in America, which is really what the goal of it was. The ACA has led to some increased access to care, and the law actually, Section 1957 actually, it's 1957, provides for non-discrimination across really in all areas. It was very broad. Sexual orientation, religion, gender, on and on and on. So it really tried to be extremely a very inclusive law, which was great. It also provides no cost and low cost birth control and preventative care, whereas before mammograms, pap smears, etc., had to have a cost associated with it. So if I have an Affordable Care Act plan, even one with a very high deductible, I can get all of my preventative care paid for, and it can be done at a private clinic as well as a public clinic. So it did extend access to care in that way. There's still a lot of barriers to healthcare, and I know that we've chatted a bit about it today. Publicly funded clinics actually historically and currently provide the majority of care for lower wage earners. See, I learned because I had lower income in my presentation and I changed it. So thank you for that comment because that was very helpful. For lower wage earners, women of color, foreign-born women, immigrants, etc., women with Medicaid and who are underinsured. But currently, one of the biggest barriers is that those clinics are becoming fewer and far between, and part of it is due to public funding, and part of it is due to our last administration, who passed a ruling that said if you refer or provide abortion and you're federally funded, we will pull your funding. So that limited the number of clinics who continue to provide abortions because they felt that was a very necessary part of healthcare for women. The ACA has, on the other hand, provided more care due to the affordability, and a shift has occurred in that 10% of women who used to receive care from publicly funded clinics are now receiving it from private clinics due to the fact that they have insurance. There's cultural and social determinants, which are barriers to care. A lot of it has to do, as you said, with education. If you're an LGBTQ person and you walk into a doctor's office and every form is only written in a way so that it makes you believe you have to be married to a person of the opposite sex, or why are you even in my office? That is not very friendly, and that is very discouraging. Also, women of color have issues because there are very few, for example, Black female gynecologists. And so how comfortable are you going and seeing? I personally don't like male gynecologists, but that's just me personally. But if I'm not comfortable, other people aren't comfortable. So that's another huge barrier to care. And also there are fewer doctors in the medical system. So we even have fewer choices at this point in time. There's also social determinants. If you are having reproductive health problems, in subcultures, that's not a very acceptable thing to have. And so it's not discussed, it's not talked about, there's no education. And so you feel kind of in this quandary of, I'm having a problem, but I don't know what to do, and I shouldn't be having this problem. So education, open discussions, and that type of thing will remove some of those barriers. Assisted reproduction is just, this is my bugaboo, honestly, and the lack of coverage that we have in this United States, where we have determined that every person has a right to reproduce and to have a family, and yet we make it so impossible for people to do so. And so in the assisted reproduction, there's just a complete lack of coverage. An average cycle will cost $12,000 to $14,000, and then you get to read the fine print. And the fine print says, and that doesn't include medication, which, I don't know, that's about another 5 or 6. And then it doesn't include the FDA testing, or it doesn't include this. So they say we have this all-inclusive package, except, right? So you really easily could be looking at $20,000 for a cycle. If you need an egg donor, you would be looking at an additional, easily 20. So not affordable. I think we will all agree. There are 19 states that have some form of IVF coverage, but I would argue that they really don't, because 9 states have IVF, 12 have fertility preservation. The problem is, like in California, they say, we have IVF coverage because it's mandated by a law, except it will only cover testing and diagnosis. If I need to get treated, I'm on my own. And you find that many of the states are written that way. New York in 2020 actually changed their law, so they include a little bit of IVF. Illinois has IVF, but they don't. So even though they say they have coverage, they don't have coverage. The private sector is actually stepping up a bit, and there are 48 companies. There's actually more than 48, but 48 companies that are published with the best benefits. Starbucks is one, Adobe is one. But again, it's limited. They might give you $20,000 or $30,000. So if you could get pregnant on the first cycle, Yahoo, but you have to also work for one of those companies. and have the benefits afforded to those companies, which means you have to be, actually Starbucks will give it to you if you work over 20 hours a week, which is nice. So the ACA does not mandate maternity and does not mandate IVF care. It will mandate maternity care. It will mandate health, preventative care, but not IVF. Medicaid will not cover IVF. So there are 9 states where it will cover testing and diagnosis, and there's 1 state where it will cover Clomid. So I guess that was pretty generous of that. That's Nebraska of all the crazy states. But Nebraska, if you need to have Clomid, will cover it, which, is kind of go juice for pregnancies.
Can you let folks know what Clomid is in case anybody doesn't know?
So Clomid is a drug that will help you produce, if you're having fertility issues, it will help you produce ovum so that more ovum can become fertile, so that your chances of having a positive cycle are good, and then you can play with your cycle timing and have intercourse or an IUI at the proper time, and hopefully get pregnant and have a baby. So, but only Nebraska does that, which I think is funny. The laws that are written, when you read them, I just go crazy, quite frankly. Because, for example, 2 years ago, actually, it was pre-COVID, so probably 2019, New York was so excited about this new law that they were putting out, but it was so discriminatory, it made me angry, because it was back to unprotected sex for 12 months, or 6 months if you had another medical condition, or if it was medically necessary, you were born without a uterus, something such as that. They've now expanded it to include fertility preservation, but they didn't change the bias. So that can be extremely frustrating. Illinois in 2021 passed a new law that they actually added gender neutral language, which was great, but you have to work for a company that has 25 or more employees and has that benefit and has benefits. So it was any company over 25 who has a medical insurance plan cannot discriminate based on giving their IVF benefits based on gender, single parented, age, etc. Which was great that they added that to the law, but it doesn't expand it enough because it's still not added to Medicaid, it's still not added to individual plans, it's still not added to certain self-funded plans, which an employer has a right to be self-funded. So therefore, again, huge gap. And to me, if you're going to write a law, and I just say this to everybody who's like, California had one that just died in the Appropriations Committee, make it an inclusive law from step 1. Don't say, well, we'll get something and then go back and change it, because no, it's not. Or it's going to take 5 years to change it because the insurance lobby is strong and powerful. So go for the gusto and keep whittling it away, because you might get it. But if you don't ask, you're definitely not going to get it. So the laws that everyone gets so excited about sometimes is, again, we're serving a very narrow community, which is those who can afford insurance or happen to work for a company who have it, and basically, quite frankly, are upper white middle class human beings. And that's not, everyone deserves to have a family regardless of that. So now I'll step back off my soapbox. So the very bottom line is that there's very, very little coverage for these very expensive procedures. And it basically then whittles it down to no one. So let's say that you get very lucky and you do get pregnant, okay? And you can use, what in off-the-grid, as Cathy was talking about, you can do in-home inseminations, et cetera, which is they work, but it's a very frustrating process because only about 1 in 4 take, and then you have to keep trying until you can get pregnant. But it is a great way to do it, actually, and much lower cost. But once you just, now we're going to talk a little bit about, so let's say we have a baby, yay, and now what happens? Well, now I'm pregnant, I need to go out on maternity leave, right, on my mat leave. Well, there are only 6 jurisdictions that have state disability insurance that are going to pay for you to be out on mat leave. And they are California, Hawaii, New Jersey, New York, and Rhode Island, and Puerto Rico. And then Connecticut has a voluntary plan that you can enroll in once you're eligible if you happen to work for a company that's offering it. Typically, it's going to be 60-70% of gross wages, but there's no taxes taken out, but might actually equal what your take-home pay is anyway. The average mat leave is about 10 weeks. But the problem with that is you're not getting paid. So you have to figure out, that's great, I'm not getting paid for this. And so what they found, again, is that women are returning to work before they should potentially health-wise, because they can't afford not to work. And the FMLA, which everybody touted as being great law, and it is good law. It protects your job. It means that you can have the time off work to pay for you to take care of your family members. You just don't get paid. And again, I don't know a lot of people that can be off work for 10 weeks and say, oh, I just don't need a paycheck, I'm okay. And so that's a huge flaw in the system. There are 9 jurisdictions that have some form of paid family medical leave. California, Connecticut, DC, Massachusetts, New Jersey, New York, Oregon, Rhode Island, and Washington are the 6. The cost varies by state. It's typically, it comes out of your paycheck. So it's typically a pretty low portion, like Connecticut's is 0.5% of your gross wages. And then employers can have a private short-term disability. But again, all of these things assume that you're working, and the private disability plan, you aren't going to pay for family leave, which means if a spouse, a partner, a significant other wants to stay home and help you take care of the baby, it's going to pay only if the person carrying the child is disabled. And then you also have to conceive on the plan. So you have to plan ahead, basically. Another area that where it just gets, again, ridiculous is childcare. So childcare, the average cost of childcare for a baby is $1,230 per month if you're at an infant care center, or $800 a month if you're doing it in home. And a non-infant, which typically is a potty-trained toddler, is about $10,000 a year. And that actually rose 5% in 2021 due to the lack of access, because a lot of daycare centers closed because of COVID and they just didn't have the money to reopen. In some areas, 20% of take-home pay is dedicated towards childcare. And that's huge chunks of money, any way you look at it. The American Rescue Act, which was Biden signed in 2021 to get us back on our feet after COVID, had a $40 billion allocated for childcare and grants and subsidies to daycare centers, as well as opening new centers so that they could have more centers be more affordable. There's proposed legislation called the Build Back Better Plan, the BBBP, to quote it, which has a $400 billion investment in childcare and early childhood education, primarily in centers, et cetera, so that affordable childcare would be accessible to all. Currently, public funding pays only for 17% of daycare, and 83% of all daycare is family funded. The Build Back Better America plan would shift that so that 71% is publicly funded versus 29%. And your contribution would be capped at 7% of your income. So you can see that would be a huge shift if that would get passed from what we currently have available to what possibly could be. There are funds and vouchers and things available for daycare, but interestingly enough, only about 5 to 20% of those who are actually eligible receive those vouchers and receive the funding. So I think that building a family in America is just darn expensive, and much improvement needs to be done in all areas of reproductive health to make it A, more accessible, B, non-discriminatory, because it's horribly discriminatory. Much more education, much more conversation needs to happen surrounding all of these areas. And it's some of it I just think is so simple. I mean, I think providing reproductive, IVF care for all, I mean, why not, and making it accessible and having those conversations. I saw a note pop up about the fact that women of color, there's very little talk about IVF or how they can access care or what they can do. And I would agree to that. And I would also agree that the access to care is very, very limited in communities that have the lower wage earners. There is you will not find an IVF clinic anywhere to be found, but you go to the upper end neighborhoods where the higher wage earners are, and there's one on every corner almost. Not quite, it's not quite Starbucks, but very, very accessible. And so it definitely has become a situation of those who have money and those who have not money. And I think that by more grassroots movements, more education, we can increase the accessible ability to care and start putting lots of pressure on the legislature, because they can change it. And so we can all change it if we work at it. So that's about it. That was a lot of information as well, but there you go.
Thank you so much, Virginia. All right, so we have a bunch of questions for folks. So I'm going to start with the audience questions, and then we have a few discussion questions as well if we have time at the end. So the first question I have is there a national or state reporting system for reporting the discrimination experienced in these reproductive experiences?
The best way to do it, honestly, is there's a governmental agency called the Center for Medicare and Medicaid Services, and they have been charged with overseeing the Affordable Care Act, which every small group and every individual plan is overseen by the Center for Medicare Medicaid Services. So it's called CMS, and you can report discriminatory issues to them. They actually really do respond because we've used them a couple times when we've had issues. Title 9, Title 10 also prohibits discrimination in healthcare. So you actually have a way through the EEOC, which sounds kind of crazy, but you can actually go up through that route also.
Yeah.
Or for doctors' horrid, you could also report them to the American Medical Association.
Yeah, and I think the CMS's official office is the Office for Civil Rights in the Department of Health and Human Services. So I was lucky enough to intern there for a summer when I was in law school. So I can tell you that they are very overworked, and you can assume that if you make a report there, it will take a very long time for it to get addressed. But I do encourage folks to report because, that's how we get change happening.
Also, if I can just jump in, the Department of Justice Disability Rights Section does a lot of health care access issues for people with disabilities, and they will take on discrimination cases. So I always tell people they should file a complaint with them.
Yeah, and in my experience, if you filed in the wrong office, but it was a valid complaint, they would often try to help route you to the right office. So don't be afraid that you're in the wrong place.
With
you
the
also can.
I was gonna say with the DOJ, you can file right on ada.gov, and that's the DOJ. So
you also can report it to the insurance company itself. Like if you have, I'm making this up, Blue Shield, you actually can call Blue Shield and say I've been discriminated in a doctor's office, because when the doctors sign the contracts with the insurance companies, they have to promise to be non-discriminatory and to follow a healthcare law. And you can also report it to the State Department of Insurance if you have insurance, or you can also report it to Medicaid if you have a Medicaid plan.
Absolutely.
Or all of these places, yeah.
Right, all of the above. Be vocal. Okay, so the next question we have is a bit longer. It says, within the Black community, reproductive health discussions are almost non-existent, partly due to religious beliefs, access, and the lack of healthcare providers. How much of this work is seeking Black women to work for these organizations like Planned Parenthood at the highest levels to shift the conversation and center Black women's reproductive health from a culturally competent lens? How many Black women work in the developmental levels of reproductive health? So I can start the conversation and you all can pick up. I was lucky as a moderator. I got a little bit of time to do some Google searching while we were chatting because I knew this question was coming. I was able to find that the percent of doctors in the United States who are Black women is an abysmal 2.8%. So if you talk about access and being able to see a doctor who will understand your experience and, have a culturally competent practice, we are talking about huge challenges. We do see higher levels in obstetrics and gynecology. I wasn't able to find specifically Black women. I was able to find that it looks like about 11 to 13% of OBGYNs identify as Black. But it is, especially when we are talking about intersectionality, it is especially difficult to get research and numbers and things like that. I spent many years doing research for the Williams Institute at UCLA School of Law, and it was a constant challenge to try to get, well, now we want to talk about ability, and now we want to talk about sexual orientation and gender identity, and now we want to talk about all of these other things that interact and intersect and are problems for folks. And it's really, really hard to get those those numbers so that we can actually have a sense of where things are at and what the conversation should look like.
And I think I talked about it earlier in my presentation, but Sister Song does do some work, and they're run by Black women. And I love them, so I always have to emphasize that. So I think that they are doing some work in this area. And I agree, representation is super important and not considered. And I put a note to myself to say also the number of disabled healthcare providers is abysmally low. And there is a lack of disability cultural competence also. So, and I think the only way we can address these cultural competencies issues is if we make an intentional effort to increase diversity.
Absolutely. And I think if Desireé were here, she would give a shout out for URGE, which is the organization that she's from. URGE is Unite for Reproductive and Gender Equity, and it's an anti-racist, sex-positive, and abortion-positive reproductive justice organization, which centers leadership of young people of color who are women, queer, trans, non-binary, and people of low income. That was directly from their website. People of low income is the term that they used on their website. But so we do have these organizations that are doing it, but there's also still a conversation to be had about, the larger the national organizations that are more well-known and have more funding, making sure that they are centering representation in their highest levels as well. Absolutely. All right, so the next question we have is a little more specific. It says, I'm a fourth-year MD PhD student planning on building a career focused on expanding access to gender-affirming and reproductive care for disabled, trans, non-binary people. From your perspective, what should physicians and medical trainees know about ART access for marginalized populations? I think we've all covered this a lot, but if you have anything more that you want to add in specifics, now would be the time.
I think I would say what I said earlier is you need to go to disabled people, work with disability justice organizations and help them or allow them to prioritize is what I should say. And I can't speak for disabled trans people because that's not me, but I would encourage you to reach out to them. And there are a lot of disability justice organizations that are run by disabled people of color and queer and trans disabled people.
Thank you. All right. Can you please talk about policies that your advocacy community promotes that actually expand access intersectionally? What does that look like for all of you? Let's start with Robyn, Dr. Powell.
Oh, Robyn's fine. No one calls me Dr. Powell, so Robyn's good. I've been called it more today than I've ever been called it, probably. So my student loans will be happy to hear that. But no, I think I wish I could come up with a lot of great things, but I think the disability community is behind on these issues. And so I don't know if there's anything specifically related to intersectionality and disabled people, like legislation wise. But I know that there are disability justice activists that are really pushing these conversations. And then just to give my own personal interest, and also it would answer a question that I saw that Cathy also answered a little bit, but there is a lot of work on parents with disabilities and the family policing system, aka the child welfare system, and a lot of states have passed laws related to that actually. So.
Absolutely. Cathy, did you want to add something there?
I mean, I think, certainly the focus of my work has been on parentage, but also I think in the ways that laws regulate ART and the provision of ART in the insurance context, as Virginia was talking about. But also I think there's a lot of ways in which there is a need for, and it is coming to have more legal regulation of ART in a lot of different ways. The protection of the health of egg donors and surrogates, of course, people acting as surrogates and egg donors, and all the way to, I think I wanted to address a little bit of what I think one of the Q&As here is, how do people find donors and how do you deal with kind of the issues that can arise with who is a donor, and if you don't know your donor or you only know your donor a little bit, all kinds of questions can arise, and this really ties into what I think is a big movement around from certain segments of people who are donor conceived and wanting more information about donors when they were conceived using anonymous gamete donors. And so there's a law in Colorado that just passed that we worked on a lot around identity release of donors at the choice of donor-conceived people, as well as access to non-identifying medical information for families, that the parents can request to, get information about the medical histories of donors. And I think these questions are really, really important because for many people, they have experienced harm, emotional and psychological, and, in terms of access and understanding their own medical history, have experienced harm in that regard. But I think this is a really important, a really important way that it's important. It's very, very important place to look at this intersectionally, because there's a lot of responses to these questions that actually also can harm many communities. So a lot of the ways that we've seen sort of the initial responses to things that kind of have been talked about in the news, like fertility fraud or people, not being able to find out who their donor was, actually creates these limitations, like you cannot be a gamete donor if you have a disability, right. Or you have to pass a criminal background check, which then further limits the ability of Black and Native donors to donate their gametes because of the discrimination in the criminal and justice system. A lot of it is framed from a very eugenics perspective. Much of it has a personhood of embryos language in it. And if you're talking about identity release of anonymous donors prior to a child's majority, so before age 18, in states that don't have protections for people using ART broadly, you're also raising a question of whether the families will be at risk in terms of being able to be recognized as the families that they are. And I think so these are really important questions to address with multiple perspectives, with all communities at the table, to talk about how can we address these questions in ways that don't just look at one piece of this issue.
Absolutely. And so you're already leading into my next question. Cathy's ahead of us. That there's clearly overlap and intersection between all of the groups and communities that we advocate for. And yet the advocacy communities can silo themselves into this false belief that each community is entirely distinct and separate from each other. So how do we build those bridges, and how can we work together to champion each other's efforts?
I think I'll start if it's okay. Inviting people is the first step. And it's, within the disability world, I'll say that disabled people are often not invited. We are seen, I don't know how we're seen, actually, we are seen as not relevant, I think, to these conversations. And when I think about reproductive rights, more specifically, disability rights and reproductive rights have sort of been pitted against each other in some ways, particularly around disability selective abortions and trying to use disabled people as pawns, not recognizing that it's actually disabled people, not hypothetical fetuses that are affected by all of these restrictions. So I really think it's important to ensure disabled people are involved and invited, and also making sure that your events and gatherings are accessible to people with disabilities, because if you are not accessible, they're not going to come. So you need to ensure that you're in an accessible location, that you have sign language interpreters and captioning and things like that. And if disabled people see that you're offering that, then they will feel welcome and they will come. And I would say that, there is some good work being done. I know that Center for American Progress has a disability justice initiative that's done some great work in this area. And there are other examples, but I think, again, it just goes back to seeing disabled people as, someone that needs to come to the table. And I would say that if you don't believe that it's important, you can go back to 2017 when there were all of the efforts to appeal the Affordable Care Act, and disabled people were the ones on the news getting arrested. So disabled people showed their ability to mobilize. And I credit disabled people for stopping the repeal of the Affordable Care Act entirely, because if you turned on the news at any moment, you probably saw someone I knew getting arrested during the whole year of 2017. And it was because disabled people have been mobilizing for decades, but it was the first, it seemed for the general population that this was a shock that disabled people could do it. And I think that you can see those efforts. And I think that as we move forward with the post-Dobbs world or whatever that looks like, disabled people need to be involved.
Absolutely. Cathy or Virginia, anything you'd like to add?
Unmute there. I think that it is very important. I agree with Robyn Powell. Invite people into the conversation. Start discussing how we do intersect, how it is critical that we do it. That when we create a law, that we make sure it's an inclusive law and that we are not excluding either knowingly or unknowingly a group of people who really should, again, reproductive rights are everybody's rights. And that's what we really need to keep focusing on, and not just, well, I'm only worried about this little section of reproductive rights, because they truly do belong to everybody. And I think we're seeing enough dissembling, that's really not a word, but I'm making it up right now, of those rights right now. And it's just, I can't tell you how sad it makes me. But anyway, I think it makes us all sad. So I think we need to really just even harder link arms all together and get this done.
Thank you. And thank you to Cathy, who just put a very extensive list in the chat. So hopefully you all can see it, of parentage cases. There had been a question about that earlier. Cathy's on double duty today, so thank you so much. And then we're almost out of time. So rather than get into the final questions, I'm going to give everybody just a final minute, and then I will close us off, of anything that you would like to share with this group as final thoughts. And thank you again all so much for being here. So let's start with Cathy, and then we'll go to Robyn and then Virginia.
I mean, I think this is such an important question and such an important topic, and I've just really appreciated being part of it. I think really in many ways it gets down to, how do we create a legal system and a society and a structure and a set of systems that truly recognizes people for who they are and how they can live their lives with dignity and respect? And this includes whether and how people choose to have children or don't choose to have children, how families are formed, and how we recognize and look at families and who gets to be a family. I think we haven't really touched much on children with multiple parents and polyamorous families, but obviously that raises a lot of other questions and issues and challenges as well, that there are so many ways, kinship care, people being raised in children being raised in so many different families that we don't really value and respect in the same ways. And what kind of a society and legal system do we want to have? And, what does it take to get there? So thank you.
Thank you.
So I would again say, thank you for inviting me. I think that just recognizing the importance of including disability issues in all of these conversations, I think, and also recognizing that disability is one of those fun clubs that anyone can join at any moment. So, you're not just disabled, you're LGBT and disabled, you are Black and disabled, you can be lots of things at once. And so that is why disabled people need to be involved in all of these movements, because every issue, I can't come up with an issue that doesn't affect disabled people. Every semester when I teach disability law, I dare my students to come up with an area of the law that doesn't affect disability law, and no one in 7 years has been able to do so. So I'm still convinced it does not exist. So disability should be involved in all of these conversations, and also just recognizing sort of how our views on disability and parenting and sexuality and reproduction have been formed by the eugenics movement, and how we still think that way. When I tell people I work on parenting with disability, people always say, oh, I have a friend who has a disabled kid. And I'm like, no, I'm talking about the actual parents that are disabled. And people have a hard time really grasping that. And there is so many studies out there that have shown that one of the number one questions that disabled people get when they're pregnant is, how did that happen? And even by doctors. I have a friend who showed up with her husband to the clinic, and her doctor said, how did that happen? And she said, I had sex. And the doctor said, with who? And she's like, the man right there, my husband. And that is something that happens every day. I mean, those stories. So how we have to just stop and think about how we think about these and why we think these ways, and sort of just change our views on these issues. And the only way to do that is intentionally, I think.
Thank you. Virginia, any final thoughts?
Yeah, I just to reiterate things that have been said, is that anything that, anytime you see a piece of legislation come across your desk, or if you have, like, I have Google alerts to kind of tell me what's going on. Otherwise I live my life in a fog, but don't just sit there and go, oh, well, it doesn't really apply to me, because it really does. As I said, reproductive rights, reproductive health belongs to all of us. And I think that the complacency of what's happened with the abortion, et cetera, and we're finally now mad. So that's good. We're all mad now. But, what happened in Georgia 3 years ago, and I said, how could a woman sign that into law, right? Because people allowed her to. That's the bottom line. People allowed her to. So I think it's just, again, a matter of all of us taking this on is our task, so to speak, and being very vocal, making sure the education happens, and telling our lawmakers this is not acceptable anymore. And the unaffordability of healthcare is not accessible anymore, and the lack of accessibility of healthcare is not acceptable. So these are all things that, if we get very vocal about, things will change. Grassroots changes a lot, and that's where it's going to have to come from.
Absolutely. All right. Thank you all so much. Thank you to all of our panelists. You're doing such critical work, and thank you for taking the time out of your schedules. The section of Civil Rights and Social Justice provides free webinars and resources for legal professionals and advocates nationwide. We hope this helps you in your work. And again, if you can, please consider joining and becoming active in the ABA. You may do so at ambar.org/CRSJ.